Good morning, everyone. Thanks for joining the Health for the World International Medicine Grand Rounds. Today, we have our esteemed guest speaker, Dr. Anna Podorlachik. She is a nationally and internationally recognized expert in interstitial lung disease. So we're really glad to have her with us. She is a faculty at Cornell University and attending at the New York Presbyterian Hospital at Cornell University. She is an NIH-funded investigator as well, studying novel risk factors for pulmonary fibrosis in humans. And she is internationally recognized in this space. So we're really, really fortunate to have her as our guest faculty at Health for the World. So without further delay, I will let Dr. Podorlachik take it from here. Thank you, Anna, for your time.
Great, thank you so much for inviting me. So I'm going to speak today about a very broad topic, which is interstitial lung disease. And so I have a lot to cover. I'll get started too, so we can cover as much as possible. My goals for today are to provide an overview of interstitial lung disease definition and epidemiology. And by the way, I'll refer to interstitial lung disease as the abbreviation ILD throughout most of this talk. I also try to demystify the classification of interstitial lung diseases, as well as define some of the more common ILDs with a focus on IPF or idiopathic pulmonary fibrosis, as well as hypersensitivity pneumonitis. There's been some recent updates in those diseases. I will also try to briefly offer a practical approach to a diagnosis of interstitial lung disease and present a brief approach and overview to management of ILD patients. So interstitial lung diseases, or ILDs, are a family of parenchymal lung diseases that are defined by interstitial inflammation, interstitial fibrosis, or other cellular changes, such as non-malignant cellular proliferation. And this is to differentiate interstitial lung diseases from the other groups of lung diseases that we see in the world of pulmonary medicine, such as airways diseases like asthma and COPD, pleural diseases, as well as infections and malignancies. So this is kind of everything else, also separate from vascular diseases. And there was at one point a push to change the name of interstitial lung disease to diffuse parenchymal lung disease, or DPLD. It never really took hold, but you may see that term also used at times in the literature. And so I put this up here just to emphasize that I'm talking about a large group of really dozens of different diseases. This is not one disease. This is just an example from a publication from 2 years ago that shows you an estimated relative distribution of some of the more common interstitial lung diseases. This is just an estimate in our general practice in New York City. These are the types of interstitial lung diseases. So 20% roughly of our ILDs are idiopathic pulmonary fibrosis, or IPF. Roughly 20% is chronic hypersensitivity pneumonitis. Another 20% might be patients with connective tissue disease related interstitial lung disease. Sarcoidosis might represent another 20%. Pneumoconiosis might represent 10%, and then another 10% might be a whole host, like dozens of other interstitial lung diseases. So this is not comprehensive, but this is just to highlight that I'm going to be speaking about a group of a lot of different diseases. And these estimates vary wildly by city and by country. And so while we might see 20% of our patients might have IPF, maybe in countries, a large proportion might have a larger proportion might have chronic hypersensitivity pneumonitis. And I'll touch base a little bit more about these diagnoses throughout the talk. So this is to highlight when I'm talking about interstitial lung diseases, I'm talking about the pulmonary parenchyma and the interstitium. So this is just to show you that here's an example of a normal lung parenchyma. You have these beautiful alveoli with very thin interstitial spaces. There's not a lot of inflammation, and there's lots of room for diffusion of gas into the bloodstream once it gets into the alveoli. This is in contrast to one example of interstitial lung disease, which is UIP or IPF, where you have a heterogeneous distribution of pulmonary fibrosis here. This is the pink areas where the nice thin interstitial membranes become fibrosed, infiltrated with cells, as well as the collagen gets deposited, and really there's much less room for gas exchange here. And so this is just to highlight what I'm talking about when we look under a microscope in terms of interstitial lung diseases. So in terms of epidemiology, ILD affects both children and adults worldwide. However, it's fairly rare in children and mostly confined to some genetic syndrome. It's primarily a disease of middle-aged and older adults. There are some younger adults with specific conditions that can also get it. In the US, 0.5% of adults over the age of 65 have idiopathic pulmonary fibrosis. And this is to highlight that IPF, which is one type of ILD, used to be thought to be a rare disease. But now we have shown that 1 in 200 adults over the age of 65 has just one type of ILD, which is IPF. There's one new case diagnosed per 1,000 adults over the age of 65 each year. So that's the incidence in the US. And in certain types of conditions, like in autoimmune conditions like scleroderma or rheumatoid arthritis, up to 33% of patients with rheumatoid arthritis might have interstitial lung disease. And in some studies, up to 100% of patients with scleroderma might have interstitial lung disease. So if you see patients with those conditions, you should have high index of suspicion for underlying interstitial lung disease. The incidence and mortality due to interstitial lung disease is increasing worldwide. And in the US, this is a high burden disease. There are roughly 100,000 hospital admissions every year for interstitial lung disease. These patients tend to be very sick once they're diagnosed and contribute to a lot of hospitalization. And the bottom line is that these used to be thought of as rare diseases, but both in the US and globally, they're moving up in terms of impact that they're having and in terms of mortality, and they're really no longer considered rare diseases. This is just to highlight, I talked about the US, but this was another study out of India looking at the ILD registry in India, where they examined clinically and reviewed clinically over 1,000 patients with all types of interstitial lung disease. And in India, the most common interstitial lung disease was found to be hypersensitivity pneumonitis, and almost half of their patients in their registry had hypersensitivity pneumonitis. The second most common was actually connective tissue disease associated interstitial lung disease. And idiopathic pulmonary fibrosis, or IPF, was the third most common, with roughly 14% of patients. And again, this is to highlight that the types of diseases we're talking about vary very widely from country to country and from city to city. Sarcoidosis, by the way, in India was the fifth most common, with about 8% of patients in the registry. So again, these are high impact diseases. So even though they're not as common as COPD or asthma, as I mentioned, they contribute to a lot of hospitalization, and they really have a large impact on patients' quality of life. Most of our patients, once they're diagnosed, they present and develop disabling exertional dyspnea and cough. They have severe functional limitation. Most of these diseases are progressive diseases. So even if they have mild symptoms at diagnosis, oftentimes over a relatively short period of time, they can develop really disabling symptoms. They have impaired quality of life. And the median survival for IPF, which is, again, one of the types of interstitial lung diseases, is still really 3 to 5 years from diagnosis, which is worse than that for many cancers. And once patients get hospitalized, their mortality is incredibly high. in one study at our center, up to 66% of patients that were admitted with acute respiratory failure and had underlying ILD died in the hospital, and a total of 80% of patients died within 1 year after they were admitted with acute respiratory failure and underlying ILD. So now I'm going to move on to try to demystify a little bit the alphabet soup of ILD, because there's a whole range of acronyms that are used. I already mentioned ILD and IPF. There's also IIP, NSIP, and many, many others. And I find that residents and attending, lots of doctors who don't work in this field, find it very confusing with all these different letters. So I'll try to simplify it a little bit. So just to provide an overview, when I talk about the classification of ILD, I'm really going to be talking about the clinical diagnosis, which is comprised of 3 different components. It includes a clinical history, exam, and lab, so really your clinical impression when you see the patient. It also incorporates radiologic findings and, when available, pathologic findings. And so you might have one type of diagnosis in mind when you see the patient, and an X-ray or a CT scan might suggest a different diagnosis, and pathology might suggest yet another diagnosis. But when I talk about the final classification, I really talk about the clinical, radiographic, and pathologic diagnosis, which is the clinical final diagnosis. So with that in mind, interstitial lung diseases can be broadly categorized into 4 categories. The first one is interstitial lung diseases of known causes or association. The second one is idiopathic interstitial pneumonias. The third are granulomatous interstitial lung disease, which mainly that includes just sarcoidosis. And then there is a 4th category that is this other category that includes mainly rare diagnoses that I'm not going to spend too much time focusing on. So in terms of ILDs of known cause or associations, there are 6 broad categories within this main category. And if there's one thing that you remember after this talk, is to try to remember these 6 boxes, these 6 categories of ILDs of known causes or associations. Why do I emphasize that? Because these 6 categories of ILDs are the ones that we can do the most about. A lot of them can be reversible because they are triggered by a particular medication or a particular occupational exposure. And if you can remove that trigger, patients can often get better. And so in many cases, these can be reversible. And in other cases, they are very treatable. In cases of connective tissue disease, for example, we can use anti-inflammatory therapies, and the disease can stabilize or even largely improve if you can make the correct diagnosis and give the correct medication. So these 6 categories, even though they are not, even though IPF or idiopathic pulmonary fibrosis doesn't fall into one of these 6 categories, are incredibly important. And and a lot of these diagnoses can be made just by taking a very thorough history and perhaps doing some basic laboratory evaluations. But these are very important categories. So the first category is ILD caused by medication. There are hundreds of medications that can cause ILD. Some of the more common ones include chemotherapy and certain anti-rheumatic medications, used for rheumatoid arthritis, for example. There's a great website called pneumotox.com that lists basically all the known pulmonary consequences of medications. And so if you're suspecting that an ILD might have been caused by medication, it's a great website to go to and look it up. Radiation is very similar to medication, but it falls into, it's one of the things that can cause interstitial lung disease when patients receive radiation for cancer. And it's also potentially very treatable if you stop the radiation and or if you give steroids. Then there's connective tissue disease associated ILD, or CTD ILD. And when we talk about this, again, there are many different connective tissue disease or autoimmune diseases that can cause or be associated with ILD. Some of the more common ones are rheumatoid arthritis and scleroderma, but there's also myositis, like dermatomyositis, polymyositis. Lupus is less common, but ILD can also be seen in that. Vasculitis, very similar to connective tissue disease, can be associated with interstitial lung disease. And then there's hypersensitivity pneumonitis, which I'll talk a little bit more in detail in the next few slides. But that's a disease caused by an immune reaction to inhaled antigens, organic antigens. And there's dozens of different antigens that have been described. There's a great website called HP Lung that lists a lot of the known antigens, but these are diseases that also have other names like pigeon breeder's disease. Again, that's a case of hypersensitivity pneumonitis that has been described in people who are pigeon breeders or people who are exposed to antigens from bird feathers, specifically pigeon feathers. This also includes diseases caused by exposure to mold and a whole host of other mostly organic antigens. And then there are pneumoconioses, which are not so common, but they are high impact. One place to read more about that is on the US CDC website and the NIOSH website. But these are diseases caused by occupational exposure. So one of the most common one is co-workers lung or black lung, that's been described in coal miners. Also silicosis, byssinosis. Again, they're not very commonly seen in the world of interstitial lung disease, but they're very important to recognize. So again, remember these six boxes because these are very treatable diseases if they're properly recognized, and it's very important to recognize them by taking a very thorough clinical history. Then I'll just briefly mention the other category, which includes things like pulmonary Langerhans cell histiocytosis, LAM, eosinophilic pneumonias, alveolar proteinosis, and genetic syndromes. These are not very commonly seen, and so I'm not going to spend too much time on, but just so you recognize that these diagnoses also fall under the umbrella category of interstitial lung disease. Then we have the idiopathic interstitial pneumonias. So what do I mean by that? So these are interstitial lung diseases that are considered idiopathic, where a known cause has not been described. And I'll differentiate that a little bit in a few slides from the ILDs of known cause, because some of these can have overlapping presentations, histopathologic and radiographic descriptions. But these are the ILDs where a known cause has not been identified. So the most common disease in this category is idiopathic pulmonary fibrosis, or IPF. And now if there's one other thing that you walk away from this talk with remembering is that idiopathic pulmonary fibrosis is not the same thing as interstitial lung disease. There are a lot of doctors that I hear that think that these two things are the same. Again, interstitial lung diseases are a large umbrella category of diseases, and idiopathic pulmonary fibrosis, or IPF, is just one type of interstitial lung disease that is, I'll define it a little bit more, but it's an idiopathic type of pulmonary fibrosis. Other diseases that fall into this category are idiopathic nonspecific interstitial pneumonia, or idiopathic NSIP. There's also respiratory bronchiolitis, ILD, DIP, or desquamative interstitial pneumonia, cryptogenic organizing pneumonia, and then acute interstitial pneumonia, a couple of rare RIPs, and then there's a fairly large category in my clinical practice of unclassifiable idiopathic interstitial pneumonias, which is a patient where we can't make a more specific diagnosis. We think they have a type of ILD that falls into this idiopathic interstitial pneumonia. They might have some overlapping features of a few of these different diagnoses, and we just can't make a more specific diagnosis, and so we call them unclassifiable IIP. In terms of the IIPs, they have been subcategorized a little bit more. So the top two, IPF or idiopathic pulmonary fibrosis and idiopathic NSIP, are considered chronic fibrosing interstitial pneumonias. And what do I mean by that? That means that they're chronic, they're generally characterized by progressive fibrosis with or without medications. They're primarily fibrosing diseases, and they're generally progressive diseases, which is a little bit different than the second two, the RB-ILD or respiratory bronchiolitis ILD, as well as DIP. These are largely smoking related. They have specific radiographic patterns that are seen in active smokers, and often disease can be arrested or stopped in patients when they stop smoking. And then the last two are cryptogenic organizing pneumonia and acute interstitial pneumonia are considered acute or subacute interstitial pneumonias. They're largely inflammatory diseases, especially cryptogenic organizing pneumonia, and they present fairly acutely. They're not chronic progressive diseases for the most part. So these are just nice categories to break things down to, a nice way of thinking about these different IIPs. So again, to emphasize that we're talking about a large group of diseases, I do want to spend a little bit of time talking about two specific diseases that we see fairly commonly in the US, and they're fairly common worldwide. And one is idiopathic pulmonary fibrosis, or IPF, and the second one is chronic hypersensitivity pneumonitis, or HP. And so I'll have on the next few slides, I'll talk specifically about these two different diseases and try to illustrate also, again, how these reflect the broad family of interstitial lung diseases. So idiopathic pulmonary fibrosis, or IPF, is the most common idiopathic interstitial pneumonia. It is a chronic progressive fibrosing disease. It affects primarily older adults, and it's more common in men and smokers. It has no known cause, and it's defined by the histopathologic or radiologic pattern of usual interstitial pneumonia, or UIP. So the clinical diagnosis here is IPF, and you make the diagnosis of IPF, I have it here, when on a CAT scan or on a lung biopsy, you see a UIP pattern, or if clinically, you can make a diagnosis of IPF. So it requires exclusion of known causes of ILD, and it requires identification of a UIP pattern on a CAT scan or a high-resolution CAT scan, or a UIP pattern on a lung biopsy. So these are very specific criteria. So we don't, again, just to emphasize, we don't call every type of ILD IPF just because we don't know what it is. There are very specific criteria for a diagnosis of IPF. It's a UIP pattern. UIP pattern means that on a CAT scan, we see specific radiographic pattern or on a lung biopsy, and I'll show you what that is. So in the last few years, in the last, I would say 20 years, there's been a lot of progress made in the treatment of IPF. And that has to do with the fact that back in the early 2000s, there were guidelines that put forward a specific definition of IPF. And it really narrowed and described very specifically what we're talking about. And so on a CAT scan, to see a usual interstitial pneumonia pattern or a UIP pattern, you need to see fibrosis or reticular changes that are in a subpleural or basal predominance, that have a subpleural basal predominance. These are reticular abnormalities, and it may include honeycombing. So to see a definite UIP pattern, you need to have honeycombing. To see a probable UIP pattern, you don't need to have honeycombing, but you may see traction bronchiectasis on a CAT scan. And I'll show you some examples of what it looks like. You also can't have features that are inconsistent with a UIP pattern. Features that are inconsistent with a UIP pattern on a CAT scan include an upper or mid-lung predominance, peribronchovascular predominance of abnormalities. If there are extensive ground glass opacities on a CAT scan, those are that's inconsistent with a UIP pattern. If you see a lot of micronodules or discrete cysts or mosaic attenuation or consolidations, these are all things that are inconsistent with a UIP pattern. So when I talk about a UIP pattern, I'm talking about a CAT scan, or I'm talking about a lung biopsy specimen. And it's been shown now that when we see honeycombing here in a peripheral lower lobe predominant, honeycombing, these coarse reticular changes with architectural distortion here, traction bronchiectasis where these airways are stretched, it correlates very well with a UIP pattern on a lung biopsy, where again, you see this heterogeneous distribution of fibrosis here in pink, next to areas of normal lung and preserved alveoli. So there's a subpleural and septal distribution of fibrosis that on pathology that correlates very well with what we see on a CAT scan. So this is a very nice and clear example of a UIP pattern. And if you see this on a CAT scan or on a biopsy and you do a thorough clinical history and you can't identify any known cause for ILD, then you can confidently make the diagnosis of IPF or idiopathic pulmonary fibrosis. This is an example again of a UIP pattern when I closer up, which is to differentiate it from a fibrotic NSIP pattern. Again, fibrotic NSIP is a different type of interstitial lung disease. And here you see this heterogeneous distribution of UIP, which is different from a very homogeneous distribution of fibrosis. Basically, all the alveoli are involved in this slide, versus here there's areas of spared lung next to areas of severely affected and fibrosed lung. And so again, here is another example of a UIP pattern, more severe, and you have also these areas called fibroblastic foci, which are areas of collagen deposition. And as you can see, it's very difficult to have normal gas exchange when you have this extensive fibrosis in the lung, which is why patients present with the symptoms of exertional hypoxemia, as well as dyspnea, shortness of breath, and cough. Here are examples of features that are inconsistent with UIP. So here's an example of central lobular nodules. This is a nice example of something you might see in HP or in respiratory bronchiolitis, but there are extensive central lobular nodules. There's actually not a lot of fibrosis. Here's an example of a peribronchovascular distribution of fibrosis. So you see there's some subpleural sparing here, and the fibrosis is primarily around the airways. So that's also inconsistent with UIP. Here's an example of fibrosis, but there's also extensive ground glass opacity. So you see lots of traction bronchiectasis. These airways are stretched, traction bronchiolectasis, but there's also very extensive ground glass, which is not typically seen in UIP, which is a primarily a fibrotic disease. Ground glass generally to us suggests that there's inflammation. So you might see this in an acute exacerbation, but if it's not an acute exacerbation, then you might want to think of a different diagnosis. So now I'm going to switch gears a little bit and talk about hypersensitivity pneumonitis. And again, I chose this for two reasons. One is because in a lot of countries worldwide, this is actually the more common type of interstitial lung disease. And two, because just like a month ago, there were new guidelines for the first time that came out that defined hypersensitivity pneumonitis specifically and provided some diagnostic criteria for this disease, which I think is going to spearhead a lot of research into this disease in the future, and hopefully we can have better treatments for it. So hypersensitivity pneumonitis is a disease of the lung parenchyma and small airways that is immune-mediated reaction that's provoked by an inhaled antigen in susceptible individuals. And there are it's now categorized into two types. There's a fibrotic hypersensitivity pneumonitis and a non-fibrotic hypersensitivity pneumonitis. And non-fibrotic means that it's purely inflammatory, and I'll show you examples of this. And even though we think that the disease is caused by an exposure to an inhaled antigen, in many patients, we actually can't identify that exposure. And up to 50 to 60% of patients, that exposure we may not be able to identify. So meaning that they might have a very typical picture on a CAT scan or on a biopsy of hypersensitivity pneumonitis, and despite taking a very comprehensive history, we just can't find the antigen that they were exposed to. It makes it very challenging. So based on the newest guidelines that just came out, non-fibrotic HP has typical findings of parenchymal infiltration and small airways disease. So you need both, at least one example from each of these on a CAT scan to make a diagnosis of typical HP. And so if you see ground glass opacities or mosaic attenuation or airspace consolidation, ground glass opacities or mosaic attenuation, that's an example of parenchymal infiltration. And if along with that you see ill-defined centrilobular nodules or air trapping in a diffuse distribution, then that makes a diagnosis of typical HP on a CAT scan. Other features that are compatible with HP include airspace consolidation and lung cysts, as well as peribronchiovascular lower lobe predominant findings. And I'll show you examples of that. In fibrotic HP, you need to see lung fibrosis that has a specific distribution, and also you need to see features of small airways disease. So you need all three of these components to have typical fibrotic HP. And so you may see lung fibrosis means you're seeing reticular changes or coarse linear opacities that are typical of lung fibrosis. And the distribution may be random, it might be mid-lung zone predominant, or it might spare the lower lung zone. Again, this is to differentiate it from the UIP pattern that we see in IPF, which is lower lobe predominant and subpleural. That is a very specific finding that we see in IPF, and that is not typical of fibrotic HP. Although you sometimes can see a UIP pattern in fibrotic HP. So here are examples. This is a nice example of non-fibrotic HP on a CAT scan. So you see again these diffuse centrilobular nodules, as well as mosaic attenuation. So you have mosaic attenuation means that you have some ground glass next to preserved lung. And this is on an expiratory scan, you see air trapping. So again, you have these pronounced ground glass opacities next to preserved or hyperinflated lung. And this is a very common feature that's seen in small airways disease. So that air, we call it air trapping because when you're exhaling, the air can't get out. So you have areas of the lungs that are hyperinflated and then areas of the lungs that are collapsed. In fibrotic HP, this is an example of, again, these coarse linear markings, perhaps in a septal distribution, along with associated with ground glass opacities. There's mosaic attenuation. There is air trapping on expiratory views. So to differentiate fibrotic from non-fibrotic, you need to have fibrosis. And so this is an example. There's also architectural distortion here, and there's just extensive reticular changes that we didn't see on the prior slide. And on a lung biopsy, to make a diagnosis of hypersensitivity pneumonitis, what you need to see is peribronchiolar lymphocytic inflammation, so lymphocytes that are infiltrating the interstitium, but really localized or largely distributed along the small airways. Again, this is a disease that's caused by inhalational exposure. And so if you think about those antigens, they're depositing in the small airways, and it's causing this immune reaction that's going into the small airways. So you see lymphocytes that are around the airways, And then you also see poorly formed non-necrotizing granulomas. So here's an example of a poorly formed non-necrotizing granulomas, as well as extensive lymphocytic inflammation. And this is, again, you can see granulomas in sarcoid. When I hear granulomas, I hear interstitial lung disease, the first thing I think about is sarcoidosis. But the granulomas in sarcoidosis are very different than the granulomas in hypersensitivity pneumonitis. Here's an example of a sarcoid granuloma. It has this nice lameral, nice circle pattern. It's very well formed. There are giant cells, there are epithelial cells, there are macrophages in there. And this is a very poorly formed granuloma. It doesn't have that nice kind of geometric pattern. You just see kind of some random giant cells here and some lymphocytic inflammation. So this is a diagnosis that would normally be made by a pathologist, but it's generally the granulomas that you see in HP are very distinct from the sarcoid granuloma. So again, to go back to the classification of ILDs, I mentioned that to make a clinical diagnosis, so a diagnosis like IPF or chronic HP, you really need to incorporate your clinical history exam and labs, the radiology that I went over, and the pathology. And so we are often fortunate enough to have access to multidisciplinary MDD or multidisciplinary discussion where we can sit down with a radiologist or a pathologist. And as a pulmonologist, I can give my clinical impression. We can incorporate all of these things into one clinical diagnosis. And so what I want to emphasize is that a histologic and radiologic pattern does not equal a clinical diagnosis. So you can have various radiologic or pathologic patterns. You can have a pattern of UIP, NSIP, or organizing pneumonia. And in the right clinical context, they can give you very different clinical diagnoses. So in one clinical context, a UIP pattern, when there's no cause, can yield a diagnosis of idiopathic interstitial pneumonia like IPF, and a nonspecific interstitial pneumonia like NSIP pattern on a CAT scan or on a biopsy, in the right clinical context can give you a diagnosis of hypersensitivity pneumonitis. If you have somebody who's a bird breather, and maybe you see a couple of granulomas on a biopsy, you might make the diagnosis of HP. And then organizing pneumonia can give you a clinical diagnosis of connective tissue disease. But in a different clinical context, UIP can give you a diagnosis of HP, NSIP can give you a diagnosis of connective tissue disease, and organizing pneumonia can give you a diagnosis of idiopathic interstitial pneumonia like cryptogenic organizing. And again, just to emphasize the point again, that in a different clinical context, these again can give you a different clinical diagnosis. So again, the history and the clinical history, taking a thorough occupational exposure, doing a thorough exam is so important in the diagnosis, because again, the clinical diagnosis really has to incorporate the patterns that we see on a CAT scan and the pattern that we see on a biopsy, but it has to be done in the clinical context and in terms of what the patient was exposed to, what do they look like on an exam, what is going on in their body. And so the diagnosis of ILD really needs to integrate the history, the physical examination, the lab data, the CT appearance, and a surgical lung biopsy. When I approach a patient with, and I'm trying to diagnose them with interstitial lung disease, I think of three components of the physical exam, and think of look, listen, and walk. So I focus a lot on the patient's skin and fingers, and I really look for subtle findings of autoimmune disease that can often be missed. And I'll show you some example of those. I listen very carefully for crackles at the lung bases in the mid-axillary line and anteriorly. And I walk the patient in the hallway or on a staircase, and I watch them breathe when they're walking, and I measure their pulse oximetry before and after walking. And I look for a 3% drop in their SpO2 that defines exertional desaturation. So here are some examples of things you might see on exam. There's an example of digital clubbing. This is often seen in IPF, but can be seen in other types of interstitial lung diseases. And we don't really understand the pathophysiology of it, but patients, especially with more advanced disease, can develop this typical clubbed appearance to their fingers. I look for Raynaud's, or I ask them about Raynaud's, and this is really their fingers turning white or red or purple when it turns cold. I look for Sclerodactyly on exam. I also look for mechanic hand. So again, there's this fissuring and scaling of the distal digits, and that's really to look for underlying myositis, which can often be missed. And I look for Gottron's papules, which is the scaling of the joints of the hands. So what should trigger an ILD evaluation when you're seeing a patient? If you have one thing from each column, think about doing a more comprehensive ILD evaluation. So if you have a patient that has exertional dyspnea or a non-productive cough, even if it's otherwise explained, think about evaluating for ILD. Or if they have an abnormal chest x-ray, if they have crackles on exam, even if you think they might be from heart failure, but if there's maybe something in the back of your head that maybe it's just not quite right, if you hear crackles, think about ILD, not just heart failure. If you see exertional desaturation, or if you see on spirometry that they have low FVC or low DLCO. If they have any one thing from each category, from each column, then think about doing an ILD evaluation. And the reason I emphasize this is because there's been many studies now that many of our patients have huge delays in diagnosis. And there was one study that surveyed patients and found that more than 50% of patients with ILDs had symptoms that started more than a year before they finally got their diagnosis of ILD. And in a setting when you're dealing with chronic progressive diseases and when your treatments might at best slow the progression of this disease, it's so important to try and make the diagnosis early so you can try and start the treatment as early as possible. So if you suspect ILD, generally the diagnostic modality of choice, the first choice is doing a high-resolution chest CT. Now, I know in some contexts, internationally, a high-resolution chest CT may not be possible, but a CAT scan really is the cornerstone of making any form of a CAT scan, at least, is so important to try and make a diagnosis of ILD. This is just to show you there's a specific protocol that's been published in the guidelines for what defines a high-resolution chest CT. I'm not going to spend too much time on this. And so usually a lot of people, when you see an abnormal CAT scan, the sort of next step that you think about is to try and pursue a lung biopsy. But I do want to emphasize that before you do a lung biopsy, you need to think about whether it's safe. And some of the features that might make you think that it's not safe is that there's extensive honeycombing or very extensive fibrosis on a CAT scan. Then both the yield and the safety of the biopsy are probably not going to be worth it. If there's pulmonary hypertension, if there are high oxygen requirements, if there's active, rapidly progressive disease, if the DLCO is less than 35% or the FVC is less than 50%, if there are extensive comorbidities, especially heart disease, if the patient is older or particularly frail, then a lung biopsy, a surgical lung biopsy may not be safe, and even a bronchoscopic biopsy may not be worth it. Before you biopsy, you really want to ask yourself if you can confirm the diagnosis without a biopsy. And we always encourage doing a multidisciplinary discussion first to really try and make a diagnosis and try to avoid doing a biopsy. A biopsy is not without risk. And if you're going to think about doing a biopsy, then you really don't want to treat patients with steroids first, because that's really going to blur the picture when you do a lung biopsy. So usually the order of things would be to do an MDD and then decide if a biopsy is indicated or not. And if it's not indicated, then we can talk about treatment. But just trying steroids is not recommended before making a firm and specific diagnosis of a particular type of interstitial lung disease. I'm going to skip this slide. So just very broadly in terms of treatment and prognosis, running a little bit out of time, so I'll just spend a few more minutes on this. So interstitial lung disease, again, characterized by inflammation and fibrosis, and the prognosis and treatments are largely guided by the fact on whether the pattern that you're seeing on a CAT scan or on a biopsy is primarily inflammatory or primarily fibrotic. The treatments are vastly different based on which category they fall into. I'll skip this. So in terms of management, there are lots of things you can do before you consider drug therapy, and drug therapy may not be available for every patient. But the number one thing to do, and why it's so important to try to make a specific diagnosis, is to try and remove the causative or contributing agent. So again, that's why I emphasize those 6 boxes of ILDs of known causes or association, because if you can find a known cause or a known association, often if you remove it, the disease can slow down or sometimes get better. Smoking cessation is incredibly important for patients that have exertional hypoxemia or baseline hypoxemia, using supplemental oxygen, having them monitor their pulse ox at home if available, doing a sleep study if available can be considered. Pulmonary rehabilitation and really trying to maintain activity and muscle mass is really important in these patients. Weight management, age-appropriate vaccination, so really doing pneumonia vaccines, to really flu vaccines are so important to try and decrease any associated mortality associated with patients getting those diseases. If clinical trials are available, if lung transplants are available, there are also online support groups, advocacy groups. And finally, the last thing on my list is drug therapy. In terms of drug therapy, it falls into 2 broad categories. There are there's antifibrotic therapies, which there are 2 drugs, Nintedanib and Prednisone. And then there's anti-inflammatory or immunosuppressive therapy, which for the most part, steroids like prednisone or methylprednisolone are the mainstay of treatments in inflammatory conditions. But then there's also a whole host of other drugs that we use. And the point here is to really, again, try to make a specific diagnosis of a specific ILD and to treat that underlying disease. Because if a patient has underlying connective tissue disease, you're going to try and treat that underlying connective tissue disease, and you're going to treat them very differently than if they have IPF or idiopathic pulmonary fibrosis. So it's so important to try and make a specific diagnosis because the treatments are vastly different. There are a few cornerstone trials. I will just mention the PANTHER trial, which was for IPF or idiopathic pulmonary fibrosis, which randomized patients to immunosuppressive therapy, and it was a triple therapy, a combination of prednisone, azathioprine, and NAC or N-Acetylcysteine for IPF. And the reason I mention this and why it's so important to make is because this was the first large phase 3 clinical trial for IPF, and what it found is that patients who were randomized to immunosuppressive therapies died more and had more hospitalizations, more exacerbation. And so that immunosuppressive therapy in IPF is actually dangerous. And before this trial was published, these were medications that were widely prescribed for IPF. And now after PANTHER, we're no longer using it. And so that, again, this is why it's so important to make a specific diagnosis, because if you make a diagnosis of IPF, then you really want to try to avoid giving immunosuppressive therapy or steroids because they can potentially be dangerous. And this study was stopped early because they found more deaths in the treatment arm compared to placebo. There are a few other trials that I'll probably skip to, but the bottom line is that in the last few years, we've now have antifibrotic therapy for IPF. There's the INBUILD study, the ASCEND study, and now last year, the INBUILD trial came out, and this is Nintedanib for progressive fibrosing ILD. And so now we have antifibrotic therapy for both IPF, idiopathic pulmonary fibrosis, and other chronic progressive fibrosing interstitial lung diseases like hypersensitivity pneumonitis and fibrotic NSIP and autoimmune-related fibrotic interstitial lung disease. So just to summarize, interstitial lung diseases are a family of dozens of lung diseases defined by inflammation or scarring of the lung parenchyma. Try to remember the 6 categories of ILDs with known cause, and that's medication, radiation, connective tissue disease, ILD, vasculitis, pneumoconiosis, and hypersensitivity pneumonitis. Remember to do a thorough evaluation. Remember that IPF does not equal ILD, that the CT is really the diagnostic tool of choice. There are non-pharmacologic approaches that can improve quality of life. Antifibrotic therapy, mainly Nintedanib, has now been shown to slow progression in progressive fibrosing interstitial lung disease. And again, try to remember to make a specific diagnosis and to treat the underlying cause of ILD. And with that, I will end. Thank you very much.
Thank you so much, Dr. Padalenchuk, for your time and for what was an excellent presentation. As a medical student, I found it very helpful how you kept things very simple and also how you characterized the different conditions that are all considered to be under the family of ILD. So thank you so much. Now we'll transition to a question segment, starting with Cameroon. If there are any questions? Can you hear us okay? Okay. While we're waiting on them, we can transition to some questions from the chat box. The first question is, when do you generally recommend that biopsies occur?
Yeah, so I try very hard to avoid lung biopsies, and I try to think about how my treatment is going to differ if I do a lung biopsy. More and more now, especially with the latest study that came out, the INBUILD study showing that progressive fibrosing ILDs of many different subtypes can benefit from treatment with antifibrotic therapies. We try really hard not to do a lung biopsy. So I only recommend a lung biopsy after an MDD discussion, after a multidisciplinary discussion. But if I'm gonna do one, I tend to do it in younger patients where it might be safer. And if I really think it's gonna, if I really have no idea what they want, and if a patient's preference is to do a lung biopsy to try and get a clear diagnosis, then I try to do it early before I try any treatments. That's really the most important. I try to avoid this diagnostic trial therapy is not really a thing. You should try to get a specific diagnosis. If you can't make a specific diagnosis, then try to make a leading diagnosis, have a differential, just like we think about many different conditions in medicine. You know, but really try to think about what you're treating, and if you're going to do a biopsy, how it's going to change your treatment.
Awesome. Thank you so much. I think Cameron may be ready for questions.
Okay. Good morning.
Good morning.
Okay. So please, I wanted to ask with relation to coronavirus infection. I wanted to know if interstitial lung disease could be a sequelae of a coronavirus infection, or if coronavirus infection could unmask a potential an underlying interstitial lung disease.
Yeah, that is such a great question. Thank you for asking it. I mean, yes, like let's not forget we're dealing with, you know, a global pandemic. So I think you're right about both. I think we are now seeing cases of patients who develop pulmonary fibrosis after a coronavirus infection. In patients, in some cases where we have imaging before their coronavirus infection that was normal. And so we've known for a long time, we thought that certain viral infections can trigger pulmonary fibrosis in general, perhaps IPF, in susceptible individuals. And so I don't think coronavirus is all that different. I think in certain individuals, it can trigger pulmonary fibrosis. We also know that patients who survive ARDS or severe pneumonia can have chronic fibrotic changes. What we don't know at this point, whether the fibrosis that we're seeing after pulmonary fibrosis, which is definitely there and we definitely see it in some patients, whether it's going to progress. And so this is one of the hottest topics in our world right now, in the world of interstitial lung disease, is, do these patients potentially would benefit from treatment with antifibrotic infection, because we just don't know if they're going to progress. I'm not rushing to start any of those patients on antifibrotics, but it's something that needs to be studied, actively investigated. And I think the other part of your question is also right. I think in certain patients, coronavirus infection can trigger an unmasked underlying lung disease. This has also been shown. There was a study that one of my friends did actually up at Harvard that showed that patients admitted with ARDS, when they look back on old CAT scan, some of them had underlying interstitial lung abnormalities that were just never diagnosed. And I think with coronavirus, as widespread as it is, with the pandemic, we're seeing some of that, where the viral infection is, in some cases, unmasking underlying ILD. So you're right, and that is, again, the million-dollar question that we need to study and actively pursue, because the virus is affecting so many people right now. So the burden of the post-recovery of anything, even though it might not be very common, because there are so many people infected with coronavirus, we're going to see large numbers of sequelae afterwards.
Okay, thank you.
Thank you.
Thank you for that. Our next question is about amiodarone and its relationship with pulmonary interstitial disease. Have you noticed any specific relationship as it pertains to duration of treatment with amiodarone and incidence of?
Yeah, for sure. So amiodarone is one of the drugs I always ask my patients about, because it's one of the most common drugs that causes pulmonary fibrosis. Yes, it's definitely related to dose. Many of the side effects with amiodarone are due to the dose. And so, I'm not a cardiologist. I know some patients need to be on amiodarone, and plenty of patients on amiodarone do fine. But when I see an ILD patient, I always ask for about amiodarone use. And if they have underlying ILD, I do not start amiodarone. If they come to me and they're on amiodarone, I really encourage them to talk to their cardiologist about stopping it. In terms of treatment, the main of amiodarone toxicity in the lung, it's really stopping the drug is the mainstay, but then in some patients you might consider steroids on top of it to try and kind of calm down the inflammatory reaction.
Excellent, thank you so much. We have a question asking about the reversibility of this disease, and what have you been able to find?
Yeah, so again, interstitial lung disease in general is such a wide range and such a wide group of diseases. Some of them are reversible and some of them are not. If it's medication induced, it can often get better when you stop the medication, when there's a known trigger for hypersensitivity pneumonitis and you remove that trigger. You tell patients, it's hard sometimes, you tell people, or if there's a pneumoconiosis and they need to stop their jobs. Often if there's a known trigger, it can get better. If you can't find the trigger and it's a chronic progressive fibrosis, then it's often progressive and it doesn't get better. And so we try to do our best with what we have. We don't have great medications. But I do tend to give patients a lot of hope, because there are a lot of medications now on the horizon. And when I try not to give averages, or when patients come to me and they read terrible stories on the internet, or they hear, from their doctors that they've been told they have 3 years to live, I try to really put that in the context that might have been an average. That might not have been enough. An average means that many patients live longer than that. And, with good therapy and with good supportive care, you can really make a big difference. And so even for diseases that are not reversible, I tend to try and give patients a lot of hope, because we just don't know. And some patients have fibrosis and don't progress. We don't have a great way of predicting who's going to progress and how quickly they're going to progress.
And looks like we may have a question from Sierra Leone.
Good morning.
Good morning.
Yes, I wish to ask. So when we suspect this, like idiopathic pulmonary fibrosis using chest CT scan, and you mentioned we should not start this patient on steroids empirically. So if the patient is presenting with hypoxia and you make the suspicion from a CT scan, you begin steroids, and the patient is not improving, or the saturation, the oxygen saturation is not improving, for how long should we continue with these steroids before maybe we give up? Or because we don't have anti-fibrotic therapy, we don't typically do lung biopsies.
Yeah, no, that's a tough situation. There's no specific right answer. I tend to so in terms of the CAT scan, it really depends on what my suspicion is for the underlying diagnosis. Sometimes, you know, you can't make a more specific diagnosis, but I try to see how much ground glass there is on the CAT scan versus how much fibrosis. If there's extensive fibrosis, there's just also traction bronchiectasis, honeycombing, reticular changes, and not a ton of ground glass, then steroids are not going to do anything for that. I try to do, you know, if you're going to try steroids to a very short course, and if the patient's not getting better, then, you know, just taper them off. It's the patient's not going to benefit from it. If anything, they're going to be at risk for secondary bacterial infection or something else. But if there's extensive ground glass, then I tend to try to do a longer course and a slower taper and really try to look for any signs of improvement. So it really does depend on the clinical picture and on the CAT scan and what it looks like. And by, sorry, I should say, if by longer, I mean, you know, you can go for weeks or even months. If the patient is making some improvements, then you can go for, you know, weeks to months.
Thank you, Dr. Podolanchuk. We have another really good question in the chat, and they wanted to know how you might differentiate on high resolution CT of ILD, differentiating that from pneumonitis induced from COVID.
Great question. I mean, you really can't. ILD, for the most part, is, except for the few acute cases, they're chronic diseases. So you'd have to have a CAT scan before they were diagnosed with COVID. But in the acute setting, I mean, it's really a clinical diagnosis, as is ILD. But again, that's why I emphasize the clinical part. So if, you know, if a patient is being admitted with typical symptoms of COVID and they're test positive for COVID, then I would diagnose them with COVID and then look for resolution of their symptoms and their imaging abnormalities over time. And if they don't resolve, then, you know, perhaps they had underlying ILD to begin with if you don't have any prior imaging. But, you know, for the most part, these are chronic diseases. I tell patients if they have fibrosis on a CAT scan, that doesn't happen overnight. Fibrosis tends to develop over months to years. And it really takes a long time for patients to develop symptoms because we have a lot of residual lung function that that doesn't manifest. You know, you can do a pneumonectomy and patient can live with one lung and have perfectly normal function. So that's what I tell patients. You need to lose a lot of your vital capacity, a lot of your lung function before you develop symptoms. And so interstitial lung diseases, again, are for the most part are chronic diseases, except for very few cases. And in the acute setting, you sometimes can't differentiate. You have to go with your clinical gestalt, your clinical impression.
Excellent, thank you. It seems like we have another question on antifibrotics. Have you found any specific one to be particularly useful, and how do you kind of approach using those?
Yeah, a great question. So we have two right now. I mean, hopefully we'll have more in the future. Again, this is a disease that I love what I do because there's so much hope on the horizon and there's so much in the pipeline, and in the next 5 to 10 years, I think the management is going to change drastically, and we're learning so much every day about this disease. But right now we have two antifibrotics. You know, 6 years ago we had none. Nintedanib and pirfenidone. In terms of efficacy, I don't have preference for one versus the other. I tend to counsel patients on the side effects, and I tend to choose antifibrotics based on the side effect profile. I didn't have time to get into it here, but pirfenidone tends to cause more upper GI side effects. Nintedanib tends to cause more diarrhea and lower GI side effects. Pirfenidone also can cause a photosensitive rash. So if a patient is active outdoors, likes to spend time on boats or garden or whatever, then pirfenidone may not be the best choice than nintedanib. But in terms of efficacy, I consider them equivalent.
Thank you. And there's another question about the age-dependent risk factors associated with CT scans. And can you speak about that a bit?
In terms of like side effects on CT scans, or?
Let's see. I think that's probably what they're getting at. I don't know if they want to clarify their question.
Yeah.
Good morning.
Okay, we have a question.
Yeah, thank you for a great presentation. Yeah, please, there is this patient that I'm following. She's about 50 years old, and she's HIV positive with good CD4 counts of about 1,000. Yeah, so she presented with about 6 months history of shortness of breath. CT scan and X-rays show typical honeycombing. And for this patient, we're in a dilemma whether or not to start steroids. I just wish to find out what your approach for this patient will be.
Yeah, it's tough. So just to make sure I understand, so you have a 50-year-old patient with HIV, but a high CD4 count that has 6-month history of shortness of breath and has an abnormal CAT scan, correct? And you're debating whether to start steroids or not. So I will say that there is an association between HIV and ILD. There's HIV and is also been shown to associate with more emphysema, but also with ILD. So when I have patients with HIV, even if they're well controlled, I do have some suspicion for underlying that they're at greater risk for interstitial lung disease. There's, again, it's a viral infection, and viral infections can trigger interstitial lung disease and pulmonary fibrosis. And so obviously you have to rule out infection, but the patient seems to have a very well-controlled HIV with a high CD4 count. And so, I don't know, I mean, without knowing, taking care of the patient specifically, it does not sound unreasonable to start steroids if there is a 6-month, progression of symptoms and you have a CT pattern that might respond to steroid, meaning that there might be ground glass and you've ruled out infection, then I think it's reasonable to start steroids and to try. Yeah.
Thank you.
Okay, thank you. It looks like the responder has tried to clarify their question, and they said that they're asking about the risks associated with having a CT scan because of the length and intensity of radiation.
Yeah,
have you noticed?
Yeah, that's a great question. So yes, I have a lower, I have a high threshold to do multiple scans in younger patients. I take care of a lot of patients with scleroderma, for instance, who are in their 20s and 30s. And so in those patients, I really try to think about how a CAT scan is going to change my management. I don't do CAT scans just to routinely follow the progression of disease. I use pulmonary function testing to follow the progression of disease. FVC has been shown to be a very good biomarker of disease progression in interstitial lung disease. So my go-to is always to do pulmonary function testing and to follow patients' forced vital capacity. And I tend to do CAT scans where there's a clinical change or if it's going to change my management for some reason. In older patients, I might have a lower threshold to do CAT scans periodically. And by periodically, I mean, maybe every year or every 2 years or something. I don't do CAT scan unless I'm looking for a specific response to treatment or if it's going to change my management. Because there are risks associated with CAT scans. Again, they're less of a concern in older individuals. And the CAT scans that are recommended as the ILD protocol, they're not the low radiation ones. They do require a fair amount of radiation. And so any test you do, you really should have a good reason to do it.
Thank you so much for that answer. And again, thank you so much for your time and being willing to speak with us today. We really do appreciate it. And I'm sure we've all learned a lot from your presentation. So thank you so much.
Thank you for inviting me. It's my pleasure.
Okay, thank you everyone also for joining. And this should conclude our webinar. Thank you all so much.
Bye.